and get started into our Q&A with the LPD representatives. So I will be leading this session. I'm going to ask a handful of questions of Captain Michon Morrow and Detective Tim Kennett. These questions are to help us understand, like Mika was kind of saying, what the current procedure police officers are to follow in a variety of situations for which they might be called involving mental health. If you have a follow-up question to the question I posed, feel free to unmute and ask it after the response is provided, or you can message me directly, or you can type, I have a question, and I'll invite you to unmute after the response. Referring back to the norms, the norms that Mika mentioned, generally holding space for each other for a difficult topic, and taking care of yourself in whatever that looks like. I think that we are going to have some great conversation off of this information that Captain Morrow and Detective Kennett are going to provide. So fabulous. Michon and Tim, would you want to unmute so you can kind of be pulled up onto people's screens? Maybe just say hi.
Hi. Good morning.
Good morning. And Captain Morrow. Okay, there, I see you're unmuted. Oh, I'm not able to hear you. If you, I don't know if Nancy, if you want to help maybe troubleshoot, if she needs to like leave and come back in or something, but I can get started. Tim, we're able to hear you. So for the sake of time, I'll go ahead and get started with the questions, and hopefully Michon can join with audio soon. So starting off with one of the questions that we have developed on this topic that we wanted to bring in here from you directly was, if someone chooses to call the police about a person that they believe is experiencing mental health issues, but are not an immediate danger to themselves or others, what is the current procedure for officers who respond to the call?
Sure. That's real general, but I would say that the officer is obviously going to be dispatched because somebody called in probably to dispatch, whether it's a friend or even the person that's involved. It could be a social service agency, or the hospitals call us, as well as a number of the mental health agencies. It could be somebody who's just on the street that somebody sees that might be needing some type of assistance. If we know they're not a danger to themselves, obviously the goal would be to get them whatever assistance they need. We have a number of options. It may be someone, if they're being called in on, they probably haven't called us, but we have options where if they want to voluntarily get some help, we have places that we can assist them in getting to. Brian West Mental Health. If they're voluntarily wanting to go there, we can take them there so they have someone that they can talk to and work through whatever mental health issue they're having. We haven't, if it's a substance abuse type issue, they could be taken to the bridge if they want to go there. We have a number of places, the Hanu House and Task, Centerpoint. Centerpoint has some walk-in, so if it's a certain time of the day or a certain day of the week, they may be open and we can just take that person there and get them the kind of assistance they need. If they're not willing to go somewhere right at that time, we can make referrals to a number, pretty much those agencies I already talked about, Task, MHA, we have a huge program with where we make referrals, and then within usually 24 hours, they'll go out and try to contact that person and see what kind of assistance they need, whether it's medical or mental health or financial, whatever's causing that kind of stress at that time. But we do make a lot of referrals to a number of agencies, but MHA is one of our biggest ones through the Mental Health Association. And I think at one point I was told over 90% of our officers had made some type of referral to them.
Michon, I had just asked Tim that first question, but Kat had mentioned, and this would be good, just if both of you, before we move on to the next one as well, could you describe your role and how that interacts with this topic? So as detective and as captain, what does that mean with your involvement with mental health crises in LPD?
I can go first. I'm a good portion of my contact is with Brian West. I'm the liaison with the hospital. So I have multiple contacts weekly working through issues with mental health. We collaborate with them as well as a number of other agencies, TASK, MHA, where I get a lot of emails where we're trying to get people the assistance they need. We have some high utilizers who we get called on a lot, or they call us a lot for assistance. And if we can hook them up with the correct agency and get them some help, then we're trying to ultimately get them the help they need. So I kind of facilitate different mental health agencies and working with different clients. We also now have a mental health coordinator, new spot that just started. And we have another individual, Detective Walsh, who does a number of things with real MHA. A good portion of my involvement is with Brian West.
Can you hear me now?
Yes.
Okay, I had to call in on my phone. For some reason, the audio wasn't working on my computer. So I'm Michelle Morrow, and I am the captain of the Southwest team, and Tim and I work together on a daily basis. My responsibility is very broad, and I would say the next layer up of making sure that we are meeting the needs of the community, specifically on the team level, for those that live within our team boundaries, but then also broad spectrum across the city with collaborations and partnerships that we have with all of the mental health service providers in the city of Lincoln.
Thanks for that background, Tim and Michonne. So yeah, for the sake of time, we're gonna go ahead and move to the next question that we had formed. This is a little bit different than the first one in the sense, so asking if someone chooses to call the police for someone that they believe having a mental health crisis that does pose an immediate threat to the person themselves. So we're curious, what is the current procedure for officers to respond to that call? And I guess kind of thinking about self-harm, walking into traffic type of things.
The officers would get there. They would try to talk with whoever called in, as well as the person involved that we're worried about. Try to gather as much information as we can. If they deem that this person is a danger to themselves, they would have several options. If they can get the person to voluntarily seek help, we have the same options. We can take them to Brian West and get them to self-admit. And once they're there, we just do a report and then they get treated. We could take them to other places if they want. Again, Bridge, if it's a substance abuse issue. If they're not voluntarily wanting to get that assistance, we can place them in emergency protective custody. And when we do that, we then contact a single point of entry who decides what location they will be taken to receive that kind of treatment. They make that decision. It oftentimes involves bed space and what's available. They could go to the crisis center, which would probably be a location where we take somebody who's more violent. They could go to Brian West up on the mental health floor. They could be taken to the Bridge. Once that's determined, then we transport and get the person safely to that location, and then they receive that treatment. There are times when there's no bed space, and we have had to actually transport some people all the way out to Mary Lanning in Hastings. It doesn't happen often, but it's happened more in the last few years than we would like. But obviously, we want them to get that assistance. We don't want them to harm themselves, so we would take steps to get them to the right location, either voluntarily or if we have to take them into custody, we would do that. I think only about 10% of our mental health investigations actually end up in emergency protective custody. So it's a pretty small number.
A follow-up to that, and Sean, feel free to chime in as well. When the officer is making that initial assessment of whether they are a danger to themselves, what are the kind of things that they are making that evaluation on in real time? Can you talk more about that?
I mean, they're taking all the information from the reporting party, and they're obviously talking to the person that we're worried about. And many times they're going to tell you what's going on and how they're feeling. And a good portion of those people will tell us if they are thinking about harming themselves, and they're actually asking for help. So we'll just get them to the right location. There are times where we have to place them in emergency protective custody, but that's not real frequent. I guess you're looking for dangerousness, whether they have immediate, is there immediate danger? Have they made a plan? Are they saying to you that they're wanting to hurt themselves? Obviously that makes you more concerned. And if it's someone who says, I thought about this 2 weeks ago, I don't have a plan, I'm just in a bad place, can I get to the hospital? We'll do that. But you're always evaluating the immediacy and what's going on right then and there.
And what if it feels like a good spot here, could you talk more about what emergency protective custody then looks like, if that is in those 10% of cases that does happen?
So a state statute allows police officers to place someone in emergency protective custody if we feel they're a danger to themselves or others. A majority of those are a danger to self, obviously. And we don't want someone to hurt themselves or potentially try to commit suicide. We want to try to get them that treatment that they need. So a state statute actually allows for police officers to do that. There's some other statutes that allow some doctors in certain situations to be able to do that. And sometimes we end up involved in that too. But ultimately, we're not arresting them for a crime. We're just placing them in custody so that we can get them to a place where they can get treatment so that they don't injure themselves or anyone else.
Thanks for that answer. I think that Mika, did you have a question that you wanted to follow up with on that too?
Yeah, I was just curious if there's some kind of like medical amnesty policy, or like somebody is afraid of calling for help because they have used a certain illegal substance. Is there some kind of policy about like if you're calling on behalf of somebody's safety and they want help, like they will not be charged for something? Does that make sense?
Sure. There's not a term that we use, medical amnesty, but we go to lots of situations that could be similar to that, where you go to someone's house, and substance abuse is a large portion of why some people are having a mental health issue at that time. I will tell you that potentially, I mean, there could be a citation or something issued, but I saw some stats the other day. We've taken 10,400 mental health calls since 2018. And in that time, we've only issued 16 citations, and only 3 times where somebody was taken to jail. And those were probably for violent crimes, not drugs. So we're really there to help them with their mental health. We're not trying to make it into a criminal investigation, and having a mental health issue is not a crime. So if they're in a situation where they're suicidal, obviously we're worried about them and getting them to a safe place. I can't tell you that couldn't happen. I mean, if we walk in and it's, unusual circumstance, we're seeing a lot of something, then maybe we would work a criminal case. But most of the time, that's not our focus. Our focus is getting that person in a safe environment so that they don't harm themselves. It's pretty rare that.
And I want.
Go ahead.
I just want to add to that we in the last, going on about this time last year, we worked with the Lancaster County Jail, and then we implemented a new jail screening program that started at the end of February of this year. And that was another layer that was put in place to make sure that we are addressing mental health needs of those that we are interacting with in the community, specifically at a point where we have taken law enforcement action. So the calls for service that Tim alluded to were the little over 10,000 calls since 2018. Those are very specific to mental health investigations, and those are with or without the possibility that we EPC'd somebody, and attempt suicides and suicides. So we have to consider that that's actually a number that's probably just barely scratching the surface of the number of interactions that we have with individuals that may suffer from some mental health illnesses throughout their lifetime. Sometimes we're getting called and it's an assault, or it is a trespass, or a disturbing the peace. And in the course of those interactions, we may determine that there was a law violation that we are taking action on, whether that be issuing a citation. But specific to the jail, if we are taking them to jail, our officers are asked to make sure that if there are mental health concerns, that those are addressed. And sometimes we have community members that are not responsive to us and that don't want to necessarily interact at that level and answer those questions. So therein lies why we implemented the new program at the jail, where they are also doing a screening process, and they're determining whether an individual that we have brought there is potentially suffering from mental health illness and is a danger to themselves or others. And if at any point they determine that they've met those two criteria, that they have mental health issues and they're a danger to themselves or others, that is triggering an evaluation. And that evaluation is done by a licensed mental health practitioner through TASK. And then they do their own further evaluation and make a determination of whether they are able to stay at the jail. And if not, we remove them. They are back with us, and we potentially look at placing them in emergency protective custody. So we are ensuring, or doing our absolute best to ensure, that they are stabilized with their mental health before we would proceed with any potential criminal proceedings with them.
I saw that Isabel had written a question in the chat. Excuse me. I'm wondering, Isabel, is that okay if I just read out loud?
I can just clarify. I'm sorry, because I'm reading it through and like my thoughts didn't really connect. So a couple of years ago, when I was in Leadership Lincoln, I did a ride along with LPD, and we had responded to a call for a domestic dispute where there was a guy who was beating his partner. And so we responded to that call, and then it turns out that someone else who was living in the house had an outstanding warrant. And so that woman was arrested at that point because she was in the house. And so I was wondering if this is like the same thing like all across mental health situations. So like if this would happen if, like, say the friend who is calling for their roommate is calling for help from LPD for a mental health issue, they're threatening to, or they're thinking about committing suicide, would that friend, if they have an outstanding warrant, then be arrested too? I'm just trying to wonder, like, what are the ways that we can make sure that folks are reaching out for help while also while also like thinking through like what are the
barriers,
consequences for myself? Yeah, what are the barriers that keep people from calling for help?
Tim, I don't know. So there's a couple of different ways, I guess. I can't guarantee that we wouldn't find out during any call for service that somebody may have a warrant. And what we have to weigh in this scenario is there is a law that provides that if officers are aware that somebody has a warrant and that's confirmed, that we are told by law that we have to make that arrest. And so sometimes in certain circumstances, it's better that we don't know that somebody has a warrant, because then our officers are put in a very difficult situation. To not arrest potentially puts our officers in jeopardy of violating a law themselves, just to make that the most simple terms. So the only way that we typically know is if we maybe know the person, or if somebody mentions it. But if somebody is simply calling in, there's no set in stone procedure that would say that we run every single person to see if they have warrants. I would suspect in most of those cases, if they're calling to get somebody assistance specifically for mental health issues, that's not our priority. I just could never promise that it wouldn't happen, depending on the circumstances, or if it is mentioned, somebody knows them, simply because that onus is on law enforcement officers if somebody has an arrest warrant that we have to take action. I mean, there's just a little bit of wiggle room in there, but it's difficult to wiggle in tight spaces. So,
Yeah, and that's what the
Tim, did you have anything?
Oh, yeah, that's what the officer had explained to me, was that like legally she was required to do that. So that's what I was like. I was wondering what both you and Tim feel about that. Does that happen often? It was just kind of really discouraging for me to see that like she was calling for help and then she ended up getting arrested for
No, that does not happen often. And you know, when we're going through all these questions, there's a million scenarios you can throw out there, and that's just one that you happen to see at that time. I don't know, and you know better than me because I wasn't there, whether there was you know, somebody said something, whether they knew them. You know, if an officer works the same area of town for a long time, he gets to know the people that live in that area, he or she, and it may be something where they knew that they had a warrant, or I don't know. But no, that scenario, in my 29 years, I've never seen that scenario. So you saw one scenario that happened one time that I've never even seen. But again, Captain Morrow's right. There's some liability there on the officers if they know someone has that warrant. Legally, they have to take some action, and there is a little wiggle room, but it's very small, and sometimes it's very difficult. And the officers aren't trying to run everybody to find out if they have a warrant. They're there for somebody who's wanting to hurt themselves and is suicidal. Obviously, we need to get them to the best place possible so that that doesn't happen and get them the help they need.
Thanks for chiming in, Isabel, and Tim and Michon talking through that question. I think that then this next question is also a logical follow from that. What are some common calls that LPD receives that involve mental health crises that would be better directed to a care hotline or a mental health professional directly, or a social worker?
I think a lot of our stuff. Go ahead.
No, that's fine. Go ahead, and I'll chime in after you.
Well, a lot of times when the call comes into dispatch, they're getting a very limited amount of information. So they don't really know what's going on, and neither does the officer until he gets there and starts talking to whoever called in or the person involved. So I'd say many times you really have no idea of the big picture that's going on. Some of those, there are crisis lines that get used a lot. Centerpoint has one, MHA has one, and many times when someone does call those crisis lines and is dealing with that mental health agency, they then call us to go out and do a mental health investigation on this person. So a lot of our calls for service with mental health investigations actually come from the hospital and from these mental health agencies, because they're dealing with someone they're not sure what is going on. So a lot of our calls are actually generated from the mental health agencies, hospitals, friends, family, the person themselves that they're calling in, they know they're in a bad place and they want some help. So I don't know that I can say there's calls that we would need to redirect. There are a lot of calls that go to those crisis lines already. And then when they're in a situation where they don't know, maybe something's not going right or it's difficult, they actually call us to assist. And there are many times I said we refer someone who's not in, they're not dangerous or in a dangerous situation, but they're having a mental health issue. And we refer to all those agencies ourselves to get the person that help. We realize we can't treat them, but we're trying to get them the help that they need. I don't know if I answered that the way you wanted, but.
I think, no, that was a start on that. Ms. Shan, did you have stuff that you wanted to offer?
I think that there is, LPD is very, very responsive, and certainly we respond to all of the calls for service that come in. And so there are individuals that I think that we are, I don't want to say it's the easy button. That's not a fair assessment, but we are the service that most individuals in our community, especially if they're high utilizers, they know that they're going to get an immediate response. And so oftentimes we have individuals that maybe, again, they're a high user just because of the mental health issues that they're dealing with on a day-to-day basis. They may have to wait for appointments. And that doesn't necessarily fit into where they're at on a daily basis. And so we do have individuals that call on a daily basis, sometimes several times a day. Sometimes it's maybe just once or twice a week. And we're just there to help them work through that point in time and the space that they're currently in. And that may be another referral. That may be a drive to Centerpoint. It may be a drive to the hospital. It could be just to de-escalate them for the day. Sometimes they just need to talk. And so we do recognize that there are certain calls for service that I don't know that needs to be a law enforcement officer, but it is about those that are calling in their thought process, that immediate response. And generally speaking, they know that they get that from us, and that we will respond to those calls and we will do our best to provide services. But the short answer is, are there some that don't necessarily have to be an officer? Absolutely.
I think a good portion of those are people that are calling into dispatch that know we will come right then and there. And once they call into dispatch, we are going to go because we want to make sure they're safe. We want to make sure there's not something else going on that we don't know about and get them help if they need it. But we know that there's a number of people that call because they want an officer to come out and just talk to them. And that's okay. But they're calling dispatch. So those would be hard to maybe refer somewhere else because they've already done that many times. They want somebody right now to come out and talk to them.
Can I add something to that? And this is more of a pat on the back for LPD. Sorry, I know it's your guys' time. But an experience that I have working on the crisis response team at Centerpoint is that we've also had several instances in where a police officer would have responded to a mental health crisis call, and they would call our crisis line, and then we can actually meet the officer on the scene with either a mental health therapist or a crisis response peer support specialist and help to de-escalate and mitigate that situation. So they've also been really good about reaching out to us to get immediate response on the scene.
And that's something we really haven't touched on. We work closely with Centerpoint and MHA and Task and Hanu House. And actually, we have a number of people that go out and teach nationally on how we do handle mental health calls in Lincoln, Nebraska, because we are one of the best departments in the country as far as we have a lot of services. We're really good at getting people to the right place, and we really collaborate with all the mental health agencies that I've been talking about. Centerpoint is a huge one. Lutheran Family Services is another one that I probably haven't mentioned. We are fortunate that we do have a lot of places that are helping us and the people that need that assistance. So I appreciate that, Chris. I probably haven't mentioned how much we meet with all of these agencies, sometimes weekly, including the hospitals.
Something.
Sorry. No, I was just going to say I interact with Centerpoint several times a week, sometimes daily during the week, and all of those conversations are about the collaboration and the partnership that we have with the ultimate goal in serving those who are most vulnerable in our community and providing them the resources that they need. And Centerpoint is just amazing. And so, Chris, thank you for chiming in. Because you were right, and we hadn't gotten to that point yet of those are very important partnerships for us, and we work hand in hand together. And the increase, the new services that Centerpoint is providing is catching on pretty quickly, and our officers are thoroughly appreciating the availability that you have to be able to come out to the calls.
We are basically at time. I want to ask one last question. There could be, if people have questions that they want to follow up with, please chat that directly to me, or just say that you want to ask that so that I can invite you in to ask that in a second. But based off this collaboration and the services to which LPD refers, one thing that had definitely come up that people wanted to ask was if as a neighbor, we know someone is having a mental health crisis and we want to get them the help, what's the process for self-referring or personal referring to those things to then, and not calling LPD first for that?
I would say if you feel strongly about that, you could call those social services or mental health agencies yourself and see if they're willing to come out and try to assist that person. Honestly, that's not the avenue that we're involved in, so I don't know how that would work with each one of those, but I think most of them would take that information, and if they aren't comfortable going out, they may call us to go out. But I would think Centerpoint and all the therapists and counselors with all of these agencies would be open to that phone call. I can't tell you I'm not in that process because we obviously don't work for those agencies, but if they're not comfortable, I would assume that they would call us, but I think most of them would reach out and take your information. Trish, you could probably answer that better than me, but. I guess, Vic, I would say just make that phone call to an agency that you think may be able to help them. And then if they're not able to, or if you feel that person needs help right now, obviously we're willing to go out and try to do some type of contact and make sure they get the help they need.
Definitely. And Chris, but yeah, I'm sure that you do have stuff to offer. So maybe when we get to the next session, we can go more into detail about that process, what that looks like. So I didn't get any chats of questions that people wanted to ask. So one final kind of check for that. Does anyone have any questions they'd like to pose for Michonne or Tim, excuse me?
Yeah, I'm curious, how long does emergency protective custody last? And that might be more of a general question too.
Sure. By state statute, once we place someone in emergency protective custody, they have to be evaluated. I think it's by a therapist or a licensed mental health professional within 36 hours. All of our reports that we do go to the county attorney, and then our reports, along with whatever the medical professional that talks with this person comes up with. Obviously, we're not involved in that. All of that gets forwarded to the county attorney. The county attorney then will decide whether they go through with a formal process to put them in front of the mental health board. Most of these do not go that direction. Usually, if we can get the person through the crisis center, the hospital, or the bridge, usually within 36 hours, they can have a plan set up to try and get them the assistance they needed where they're not going through this mental health board process. They set up services for them, they stabilize them so that they're no longer suicidal, and they can be out as quickly as one day. If it's somebody that's a very severe case or they're very violent, then that can be longer, but typically it's probably less than 2 days. Many times just 1 day, because a lot of people that are in that point that are EPC, they're placed in emergency protective custody, they're in a really bad place, and we don't want them to hurt themselves. And if we can stabilize them in not the police department, but these medical facilities, then they can get them back out to carry on with their everyday life.
Thanks for asking, Kieran.
And I was I was just going to add really quick, that's a very general, broad answer. And I just want to point out that that's probably about the only way we can answer that, is because once we place somebody in emergency protective custody, there generally is no follow-up with us. And that's done intentionally, that it's then outside of law enforcement's hand. We are certainly the trigger. We are the ones that have the authority by state law to place somebody into emergency protective custody, but then we hand it off. And that falls then with the mental health professionals to continue to help evaluate and support that individual. We know generalities, and sometimes it's because we interact with these individuals again, and so we know the outcomes, or maybe on that very, very small percentage, we might actually have to go to a hearing.
Thanks, Kieran, for asking that, and Tim and Michonne for your answers. Allie, I see your question. Are you okay with? I think that maybe if we table that and ask in the next session, I imagine we'll be able to get some pretty descriptive answers for that too there. So thank you, Captain Morrow and Detective Kennett, for joining us and providing these answers to questions that are often very, very mystified or veiled to a lot of us. So yeah, thank you for joining. And yeah, hope you have a good rest of your day.
Thanks, guys.
Thank you. Have a great weekend. Take care.
Thank you so much.
So I believe I am passing it off now. You don't get to hear from me anymore.
I highly doubt that.
Okay, so yeah, we wanted to talk to LPD, kind of demystify their process and procedure. And now we have Chris Allen. I don't know how to say your last name, Chris, but I think it's Allen from
It's Spanish. It's Allende.
Allende. Okay,
Yeah.
that makes a lot more sense. Cool. Okay, so Chris Allende and Heather Coleman, who are part of Centerpoint's crisis response hotline. So they're actually working right now. So if one of them has to leave in a hurry, they might just be doing something super important, and we appreciate that. Thank you for spending part of your Saturday with us today. So we had sent you guys some questions kind of about situations that happen in our neighborhood, both with businesses and more individually, and like how you guys respond to that and what your thoughts are on them that we composed. I wrote so many questions. I had to trim them down a bit because we wanted to give opportunity for you guys to also be a part of that. We also have Allison here, who I know works for Hope Spoke, but you're also maybe not representing them today. You might be coming as an independent practitioner, I was told. So if you guys briefly want to just talk about your role and what you do, and then we'll get into the questions. Let's start with Chris, Heather, and then Allison.
Yeah, so you just want like a brief synopsis of what we do? Is that what you're asking? Okay, so my name is Chris. I'm a crisis peer support specialist at Centerpoint. And it's actually not just a hotline that we run, even though that is part of what we do. Our services are actually divided into 3 parts, so to speak. We do have the crisis hotline, which is available 24 hours a day, 7 days a week. There's always somebody that will answer that line if you're experiencing mental health issues. But we also have walk-in services that are available, hold on now, because our hours just changed. Monday, Wednesdays, and Fridays, 8 to 5. Tuesdays and Thursdays, 8 to 7:30. And then Saturdays, 9 to 1, if I'm not mistaken. All right, I got it. So that we're doing that. And then we also offer field response. During off hours, field response depends on certain variables, who's calling, what the situation is, and things of that nature. But during the week, during those working hours, we do offer field response basically for anybody who would need it. If they feel they can't come into our office for services, if LPD calls, if Brian calls, if St. E's calls, if any of our partner agencies calls and they need us to go out and to attend to somebody, then we can definitely take care of that and hit the road.
All right, Heather and Allison.
Yeah, my name's Heather. I'm a crisis response therapist at Centerpoint. I do a lot of what Chris does. I do walk-ins. I'm actually on crisis line right now, and I am on call this weekend. So if LPD would need me, they call me up and I would be the one going out this weekend. So I'm doing that this weekend. But also as a therapist, I do like assessments. So if one's like in an emergency of needing an assessment, I help them with that. And so we also do, so if someone is suicidal, we do safety plans. We do LRAMs with them, assessing their safety if we call LPD if they are needed. But yeah, we do a lot at Centerpoint.
And I am Allison Richardson. I am a therapist at Hope Spoke. I specifically, at the current moment in time, work in their group home. Much of my career has been spent with adolescents, specifically teens. Prior to being at Hope Spoke, up until about a year ago, had actually worked at Cedars. And so also knowing some of the services that they're aware of when LPD does have contact with someone who is a juvenile, that goes a little bit of a different route and routed to juvenile probation. And having some specific officers to address those issues. And kind of that partnership also with Cedars is something that I have been working at prior to this past year. So I'm hoping to offer kind of experiences from both of those locations today.
Awesome. That's great to know that we have perspectives on the juvenile or the youth part and the adult part. That's great to know. So thank you guys so much for being here. Let's just jump into the questions. These questions were sort of generated from concerns we've heard in our neighborhoods and even specific instances that we've encountered in our own neighborhoods. So the first one I have here is just knowing, is it important to kind of know what sort of mental health crisis someone might be going to, or if going through, or if maybe it's a substance abuse issue? So is it even, if you're going down the street and you see somebody that's experiencing something, is it even important to know like what that thing is? I know there's multiple perspectives on that, which I was surprised by, but yeah, I'd love to know what each of you think about just identifying what might be happening, and if it is important, like what indicators might differentiate between them that are important to take note of.
I'm going to say no. I'm going to offer a different perspective. And again, there's, as you said, there's a wide variety of perspectives on this. I think diagnoses are helpful for insurance companies, and it kind of begins and ends there. Some people appreciate diagnoses and provides a lot of clarity of this is the answer to all of these symptoms I'm having. But this is a personal belief. And so how I practice, that after I send it to an insurance company, that's about it. It's shorthand for a list of symptoms, but it only matters so much as the symptoms are bothering you, right? So if I see somebody walking down the street and where they tell me they're having hallucinations or delusions, it doesn't matter to me if their diagnosis might be depression, and they're having some psychosis related to that. If their diagnosis is schizophrenia, that being what their diagnosis is, to me isn't important. I think it's a lot more important to know what's bothering you, how are you feeling, what's upsetting, what's frustrating to you. So I think the symptoms are a lot more important than the names we give them. And again, I'm on that end of the spectrum. Other people really appreciate the diagnoses and think they add a lot of clarity to situations. But I think, especially just in interacting with somebody, just knowing what's bothering them, the symptom is much more important than the name you want to give it.
I would agree wholeheartedly with Allison. As a peer support specialist, diagnosis for me isn't really that important. A big part of my job is connecting with people where they're at. Doesn't matter where they're at, but connecting with them there, and then supporting them on the road to whatever wellness looks like for them. So diagnosis for me really doesn't play a big role in it. I mean, it can add some clarifying, it could add some clarifying data, but it's not a big part. It doesn't really matter to me or the role that I do.
I would also agree, because I feel like this day and age, when you hear someone has a diagnosis, we're automatically just stereotyping them. And I don't like to do that to people, because I rather focus on, okay, what is bothering you? How can we problem solve what's going on? How can I help you? And so the diagnosis doesn't really play an effect into it, except for, okay, you are having hallucinations. What can we do? What are they saying? How can we combat that? Are we in reality? Are we not in reality? In working around that to the point that diagnosis doesn't really play an effect into it. Because again, I feel like we are just stereotyping them when we hear they are schizophrenic or, oh, they have a substance abuse problem. And so.
It also runs into the barrier too when people do self-diagnose. I mean, I am the worst at it. If I go Google my symptoms, I tell you exactly what I have. And so it also creates some barriers sometimes when people say, I have depression, I have bipolar disorder. On paper, that's a very different thing to my personal experience. So it's almost, for me, I think it's almost can be a barrier to put that label on. So it's like, let's just talk about what's going on for you versus what you want to call it versus what I want to call it versus what the hospital wants to call it. Let's just talk about what's happening.
Wow, that's very clarifying for me as somebody who has zero experience with this, because I was asking Jacob, who's also from Centerpoint, who's here, I sent the questions over, and I think either Chris or someone named Cole, who I don't think could make it, responded, and they also said, it doesn't matter. So I think there's consensus among everyone we've talked to who's a mental health professional that it doesn't matter, and I think that's really useful and interesting information for me too. So thank you for that insight. This is another question. Ooh, Mika has a question too. Well, I'm gonna come back to it. So what sorts of things should residents take into account when considering if and how to intervene if they're concerned about an individual's safety or the safety of others? And I didn't get super specific with this because there's so many different situations. So if you think of something specific that you want to use as an example, feel free to do that. But kind of generally, if you see something on the street and you're like, should I do something about that, or what should I do about it? Like, what sort of triggers should maybe someone go through in their mind to kind of decide how to move forward?
Doing the awkward trying not to talk over people or talk first all the time. I think one of the biggest things when I thought about this, which to be totally transparent with you is a little bit counter to what our training is. And I don't know about Heather and Chris, as mental health practitioners, it's a little bit counter to our training. And so this is kind of a new learned thing that I've been thinking about, especially as we're having larger conversations about checking biases. And so when I started thinking about this in crisis intervention, is really asking the question, is this a safety concern, or am I uncomfortable with the symptoms that I'm seeing? My discomfort does not constitute an emergency for somebody else, especially somebody who lives daily with some of those symptoms. To me, it might be very upsetting or off-putting to see somebody, having interactions with somebody that they're hallucinating with, or, their delusions. That might be really uncomfortable for me. But really assessing the question and asking yourself, are they actually in harm's way? Are they in a location that's dangerous? Are they close to walking into a street? Might be very different versus, they have a big display of emotion, they're crying on the street. So the first question I think I've been thinking about for this is really asking, is it an emergency, or am I just really uncomfortable by what's happening?
Quite frankly, I think that was a great answer. I've got nothing else. That was an awesome answer.
Yeah, I agree with her. The other thing I would add is you just never know what someone is actually going through. So even if you are uncomfortable, just saying, hey, how is it going? Just like having that short conversation, because if they might be suicidal, they could be having a problem where they just need to talk, and you can refer them to, oh, here's a crisis line number that you can talk to. Absolutely. You don't have to spend hours with this person, but just making sure that they have a resource to talk if they need it. Because my first thought was suicide. Okay, you don't know what someone's going through because they could be just there, and we don't know it. And so that's the one other piece I would add.
Yeah, that was thoughts.
Sorry, my perspective is a little bit different because when it comes to that, like I don't jump to those conclusions often. My whole thing, honestly, and just being a peer support, I think it's part of my training, is really just connecting with people. Like the vast majority of my conversations start with, hey, what's going on? And that just opens up a floodgate to a lot of different answers. So truly, my experience has been that a lot of times people are just looking to be heard, and having those conversations and just, getting over your personal biases, like Allison was stating, and maybe that uncomfortableness that you might be feeling inside, and just sparking up a conversation. And I feel like most situations can be resolved with a conversation. I really do.
I think of the whole thing, if I could kind of summarize what my experience has been in the field, but also what I could offer to other people who are thinking about how to respond, is the relationship before the crisis is going to dictate the outcome of the crisis. There's research in the field that 70 to 80% of the effectiveness inside a therapy setting with a professional is a direct relationship, or in direct correlation with the quality of relationship. So if a client feels cared about, is going to dictate the outcome of that therapy session much more than the quality of the intervention I use. So no matter what I say in the room or what I do or activity I plan, no matter how great it is, if the person doesn't think I care about them as a person, really I'm wasting air time, money, all of the above. So really thinking about if there is someone that is predisposed to mental health or substance use issues, really the time to intervene is by building a relationship with the the crisis happens, which isn't always possible, right? We know that. Sometimes we don't know there's an issue until there's a crisis. But thinking about in a community neighborhood setting, how intentional can you be to build a relationship with people so you know, one, maybe what their symptoms are before there's a crisis. And then when you approach them during the crisis, they perceive you as a friend and an ally and support versus just some random stranger on the street that thinks they're weird. So I think thinking about how do we prevent the crisis and have that relationship beforehand, because that's going to dictate the outcome more than anything else that we could possibly do professionally or just in the community.
Yeah. When I was saying my answer, I thought I was just saying, like, if I see someone on the street and I just think they're having a hard time, absolutely, I'm going to be like, hey, how's it going? And then make sure that they have their resources. But when they're coming into me, they have my undivided attention, absolutely 100%, because I'm going to be that person that they need to talk to. Like Chris said, they just need to talk, and majority of the time, they just, I don't know about anyone else, but you just keep things in. And then talking to some person with no judgment whatsoever, then they're going to just like say everything. And then they're going to walk out feeling just so much better because they got everything off their chest that they needed. Absolutely. And so that's where we do have to set aside our biases, because there's going to be people who walk into our offices that are talking to someone we can't see. They're going to be hearing things we can't hear. They're going to be emotional, and we have to set aside our biases and our uncomfortable to help them.
Totally agree with you, Heather.
I'm gonna jump into, so we kind of talked about, I love this because it makes me think, like, in the center of your mind should be empathy for the person who's experiencing the crisis and whoever else is around. So starting with the empathy, and then identifying, is this a safety concern or am I just uncomfortable? And then maybe going from there to be like, hey, what's up? How are you doing? Is there anything, then maybe checking in if you feel like it's not just your bias and there's something that maybe needs to be addressed. So if you come into one of these situations, what if I had like two numbers on my fridge, one for like a mental health hotline and one for a substance abuse hotline, whose phone numbers should I have on my fridge to like give to people when I realize maybe this is a resource that they might need? And you can say yourselves, like, that's cool.
I've got biases, and I'll recognize that, right? And I would say that we can probably handle both of those situations. I mean, you only really need one number in my mind, and it would be ours, because we could definitely, refer you whether to ourselves or we have a pretty solid handle on the resources that are available within the community. So, but again, super biased.
I'll back it up. All of our paperwork, when we have to put a crisis number, that's always part of our thing at the bottom. It always says Centerpoint too. No matter what agency you work with, that's pretty consistent, Lincoln.
Okay, follow-up question. So if we call the hotline, or this individual calls the hotline, like, what can they expect? Like, should the individual, like, because when there's a police call, in my belief and perspective, like, you should stay with if you had to call on that person for a mental health emergency and you didn't know any other resources and you didn't call Centerpoint, you should wait with that person or be present with that person until help comes. So with calling a Centerpoint hotline, should you just like wait with that person until, is there like a Centerpoint vehicle? Like, what's the process for that?
So I guess it would depend on who's calling. Is it a community member or is it the person that's in crisis? If it's a community member and the person in crisis is available to talk, I would probably just ask to speak with that individual, because what I want to do is connect with them and see what's going on. Depending on what's going on, then we could take steps. Again, we do have the option to go to them in the field if maybe transportation is an issue, which tends to be for a lot of people, or if maybe they just can't come in or don't feel comfortable coming in, they have traumas that don't really, they don't like to be in that kind of clinical setting, or whatever the case might be. We can definitely respond to them, or we can have them come in. And a lot of times, I mean, I feel like we overcomplicate things sometimes. And I really do feel it's as simple as just having a conversation. What crisis means to me is maybe not the same thing that crisis means to you. So what crisis are they going through? What is it? Is it resource? Is it about resources? Are they maybe getting evicted and they can't afford their housing and they're struggling because they need rental assistance? Is it maybe there was a question that was asked that their meds ran out and they don't have the money to buy meds? Or is it maybe that they're just experiencing a different reality? There's so many, or are they experiencing suicidal ideations? Like, what's going on? And depending on what's going on, then we can, you know, create a plan to help resolve or support them in whatever is their situation, basically.
I guess what I wanted to just clarify, I guess what part of what I'm thinking about is that time-based response. So what LPD was they mentioned that part of why people are calling LPD is because they know pretty much immediately someone can come on site and help them. So you know it's going to be addressed in some way. Is that the same reality for CenterPoint, or would it be kind of like maybe you call and maybe someone answers, or maybe you have to call again? Or do you know that there will be an immediate response, or is there like a sort of delayed response where maybe they're like, oh, you'll have to call again tomorrow? Like, do you see? Yeah. So that's kind of part of what.
Yeah, so from what I've seen, we have, during working hours that I mentioned earlier, we literally have a team of 6 people on our crisis response, and we have a bunch of different lines that are all connected to the same phone. So when people call in the crisis line, it's getting answered. There was a span there maybe at the end of last year where we were low on crisis therapists, just being completely transparent here, where you might have had to leave a message and we would call you back ASAP, but right now that phone's getting answered. And it's been that way all this year. So if it's during working hours, we've just shifted our model with the CCBHC grant that we got. We've actually expanded our crisis response services. We've doubled them, really. So starting August specifically, the things that we're doing look a little bit different, where we are adding that field response piece, where before we did not. It was only youth related for system of care type situations. But right now we are definitely available specifically during those working hours. Off hours, it just depends on the situation. Yeah, but if somebody calls me right now that they can't, you know, they call Heather because she's on call. They call her, I can't, I can't come in, but I'm experiencing this, this, and that. I really need to talk to somebody. Then Heather can definitely go out there and meet with the individual and help mitigate their situation. Yeah. So I would like to say that the lag is very, very short. Are there instances where there might be a gap? Yeah, but that's not the norm.
Yeah, we have, like Chris said, we have a bunch of people answering our phones, and when it's off hours, we have contractors who are answering that phone, who are trained to answer that phone. And then if we do get called out, we have a amount of time that we do have to be there on site. I believe it's 20 minutes we have to be on site with LPD when we get called out. Because with Lincoln being a pretty big city, I might be on north side and I have to get the south side, and it's going to take me a little bit to get there. So we do have a set time we have to be there, but we are talking to them on the phone, and if we're going to be a little bit later, and trying to problem solve and just talk to them while we're getting there. And then when we get there, police, if we're called out by the police, they are debriefing us, or the person's just carrying on that conversation we had in the car. But yeah, there's always someone answering our phone, and we do go out and we make sure that we are connecting with the community.
And if I can also add, one of the main things that I want to take away from this, and especially when you guys are sharing it with your circle of influence, is that there is help available, and it's available quickly. You don't need to be experiencing whatever crisis or whatever situation it is by yourself. I mean, there is support that's available, and we can make it happen quickly. So definitely let that be known. Let that be the messaging, that you can call us and we will get out there and we will support you through whatever it is that's going on. You don't have to go through this by yourself.
Yep.
That's super easy.
Yep. The line is 24/7. And so you can always call. If it's like 3 a.m., someone's going to answer that phone.
Thank you for those responses. I'm going to ask one last question that was I think you kind of answered one of the questions I formulated, so we're just going to skip it. But I have one question specifically thinking about businesses and organizations that are in neighborhoods where maybe there's a lot of people that have mental health issues or mental illnesses or are struggling with substance abuse. And if you're at a business or organization and this is in some way like disrupting the workplace environment or something of that nature, like what are some things that businesses can think about before those things happen, to kind of mitigate it, and also just make the whole experience better for the person that's having the mental health crisis, but also for their customers, where it's like this kind of soft discomfort that's often just a bias actually can have an impact on your business or your organization, even though it's like maybe just the discomfort of your customers. So thinking about that, and then, yeah, I'm just going to leave it there and just, I can also ask the actually well-worded question I wrote, but I just wanted to keep it.
So I would kind of piggyback on what Allison was saying earlier, where that pre-existing relationship. So as Centerpoint, we also have an outreach team, and the outreach team is very well, is very well connected with the Downtown Lincoln Association, the DLA, and they are in close contact. And I know some of you guys might know Matt Martinowski and Cole Dickus. They are our outreach team, and again, have a very good relationship with the DLA. And basically our consensus is the pre-existing relationship plays a huge role. Specifically in the downtown area, you kind of get to know who are the individuals that hang around certain areas. And there is the possibility for a pre-existing relationship. I feel a lot of it does have to do with getting over maybe that fear that we've been talking about, and approaching people as humans, because at the end of the day, that's what we are. We're all humans. Let's just have a conversation. Let's talk about it and build that relationship. Because if I get a call, for example, from the DLA, and they're like, hey, we got so-and-so down here that they're doing whatever it is that they're doing, what I'm going to do is I'm just going to go up to them and start talking with them to see what's going on. And it really is that simple. Just having those conversations and being able to connect with them. It's truly that simple, in my opinion.
One thing I'd like to add is a good timing with the question, because yesterday, Matt Martinowski and Cole were working on a workflow with the Downtown Lincoln Association regarding this. So yeah, more to come. Just like an official type workflow of like who to contact first and such. So that was cool. Timing, it's awesome.
I always find, I grew up in the South, so I always blame it on that, but food solves a lot of problems for me. And so I am always just, hey, let's try to, especially when something is unsettling, and the reality is there are going to be biases that exist. We're not anywhere close to getting rid of some of those. And it could in reality have an impact on business. Drawing the person and saying, hey, we got some snacks in the back, or let's go grab a coffee next door, and walking with somebody, one kind of helps put someone in control of the situation of let's move to a place where maybe you have some privacy to kind of deal with whatever symptoms are going on. But man, if people offer me food, I'm bound to go almost anywhere with them. It's helpful. It also meets that hierarchy of needs. Sometimes just needing food, needing some, sustenance will help kind of mitigate that. I think if I've learned anything in working, especially with kids and teenagers, is the best crisis management also works to prevent the secondary crisis. So somebody else having a big reaction to a mental health symptom they're seeing over here. So if you are in a situation where there is a mental health crisis in the workplace, the best thing that I've learned, sometimes the hard way, is having one person designated to be the person to check in with the other people who aren't in crisis. Because if someone's checking in with you and you're saying, hey, how are you doing? I know we've got something going on over here. Can I help you find anything? And redirecting and just offering that kind of peace and comfort in the moment can sometimes just help other people in the situation feel uncomfortable that might not naturally have the most helpful response in the moment, and prevent anything else from flaring up as a secondary crisis.
Okay, I think I know we have a lot of questions in the chat, so I really want to get to those, but I do want to follow up with this one because we have some organizations here, and our office is located on 11th in a busy area, so we see stuff sometimes, and normally we know people, or we like those relationships are really important. So there's that, but then the Cultiva staff, I invited some of them to come, and I know like a couple weeks ago they had an experience where it was like a mixture between like a just a safety issue and also a mental health crisis at the same time. There was a guy like kicking someone's car and like they're just yelling, so the manager had to come out and like de-escalate the situation, and luckily he had experience with direct service, so he kind of knew what he was doing. But for those of us that don't know what's happening, and maybe there's not like a weapon per se, but someone's just kind of being aggressive, or like there's a guy I know that walks around in the neighborhood who like will yell at your dog while walking by, or he's just like kind of unstable, and it's just kind of, you're just like, I don't know what he's gonna do. So what kind of, do you have any suggestions for situations like that on de-escalating something if you don't feel comfortable calling the cops right away because maybe it's not quite there, but if you have a sense that like maybe this is a safe, like a safety situation that could escalate, what are some ways that someone might de-escalate that if they feel safe and comfortable doing so in a business, if you're at your work?
That's a great question, and are there so many kind of confounding variables in that. I'm trying to think as to give a good answer as kind of holistically. I think your comfort level needs to play a part in it as well, and kind of assessing how serious is this. Someone's aggression towards a car. Again, I work with teenagers who have a lot of behavioral health issues, so I see a kid kicking a car, whatever, cars get fixed. People don't as easily. And so really thinking about how serious is this situation? How comfortable do I feel? If I'm thinking about, it really comes back to that empathy of, hey, what's going on? You look like you're really frustrated. It looks like you're going through something. How are you doing? And really coming at it from, how are you? Is there anything I can do to help? Do you need anything? I think one of the biggest tools, and this is something that after I read about it and have started to implement it, I've seen huge impacts, is the ability to co-regulate, is kind of the fancy research word for it. But the research out there really shows that people in close proximity, their bodies actually will start to co-regulate their heartbeats. They did a research study of people at a concert in close proximity. After a certain period of time, their hearts actually started to beat, started to regulate with each other. And so what we know, kind of based on some of that research, in addition to others, is that if you as the person in the situation can remain calm, your physiologically, you just being there will help provide a calming presence. Sometimes we talk about it in the terms of vibes or having a good energy, but the scientific backing to some of that is that when you're calm, you physiologically have a calming effect in the people that are around you. So really thinking about, what can I do to take a deep breath? How can I make sure my voice is calm? How can I make sure that my physical presence isn't threatening? Can I stand a little further back? Can I kind of tuck my shoulders just to not feel imposing or threatening when I check in with this person? So if you, one, assessing how serious it is, if it's something that you feel like needs to be intervened on, and some of this is going to be personal judgment and reading the situation. And then the second one is going in with that empathy and non-judgment, asking how you can help, offering assistance if needed. That listening ear that Heather talked about can be huge. But then also keeping yourself really calm, because the more escalated you get helping, which is, this is much easier said than done, the calmer you can stay, the more likely it's going to have a calming impact on the person you're trying to reach out to. So that's a really good non-answer for you, but some of the things at least I think about.
That was a great response. I think that's really useful. And of course, if you don't feel comfortable responding, you can call one of these guys, and then they can, hopefully someone else can come out and respond to that. So I want to get to the questions in the chat. We have a number, and I'll just read. Mika wanted to know if you have any insider experience on the impact of emergency protective custody for the people that are put in that situation.
Yeah. And again, people are unique and people are individual, and the way it impacts one person isn't necessarily how it's going to impact another. But as a whole, it seems to me like that traditional model of calling the police, hospitalizations, and EPCs tend to be more traumatic than not. And it tends to re-traumatize individuals, and it tends to not, in a lot of instances, it can do more harm than good, in my opinion, which is why I am more for handling the situations in a different way. I feel, me personally, like calling the police on a mental health crisis isn't most most of the times it's not the best course of action. I feel like there's a lot of other things that can be done, because my experience is that when somebody does get EPC, they usually get locked in a room, get given meds, and really aren't treated as human as they possibly could be. And it tends to just really not do a whole lot of good. There are instances in where it is helpful because people do get stabilized on their meds, and there is certain benefits that could be reaped from it. But I am of the opinion that if there is any other course of action that can be taken, that is the course of action that should be taken.
I think the best
response. Oh, actually, sorry, Allison, please.
No, I'm so sorry. I think the best emergency protective custody is one that gets to be voluntary, which again makes it not an EPC. But anytime when I've had to identify that it's really a safety risk or that somebody might really need, especially, it's not even called CAPS anymore, but the adolescent side of the Bryan mental health will forever be called CAPS, I think, in the field. Getting a person to a point where it becomes a voluntary about, wow, I'm so concerned about you, when you offer that concern and recognizing it. Also, when it's voluntary, they also have the choice of when it ends. In EPC, you don't. So helping people get to that place where they will do it voluntarily has been where I've had the most success. And it seems less traumatic because there's choice involved.
We have a question that was posted anonymously. So considering people who have repeated concerns and they have to call the cops on a regular basis, almost a daily intervention, like LPD mentioned, food access, housing, and medical care. I need to just read it. I'm just going to read it more thoroughly. I thought I could summarize it, but I didn't do a good job. So I'd love to hear from them about the common quality of life concerns of people who need repeated, almost daily intervention, like LPD mentioned. So I think when they say common quality of life concerns, that's the housing, food access, and access to medical care. I'm not, if you want to clarify that, I'm a little, okay, let me see.
I didn't even mean to pose it anonymously, just if you had time. That was my question about just of the folks who are having to call, like LPD had mentioned, they get daily or at least weekly calls from people who either just want to talk or need intervention on a very often basis. Do y'all as providers see some of those common quality of life concerns, and what are those that you typically see of like medical care, housing, food access, such as that?
I think all of those, anything that makes someone's life difficult. We all have a threshold to experience any mental illness, right? Some people's are really low, and just kind of daily functioning might trigger a mental health crisis or a mental health experience or a mental illness experience. Everyone has a threshold for that. And so the more challenges and barriers you put in place, not having access to food, homelessness, a lack of a support system, all of those things are just going to make life harder. I think the one thing that we haven't talked about that's a huge part of my work that really plays into this is the experience of trauma and what we know about trauma. I think I could boil down most of the DSM to trauma responses. All of our diagnoses can be understood through the lens of trauma. And so I think the more traumatic experiences, which would also include not having access to food, homelessness, not having basic needs met, I think is probably one of the most common denominators, or how I would boil down almost everything that I see in my position, at least. I'm sure Chris and Heather will have more eloquent.
Yeah, definitely. I mean, what you're saying, Allison, is absolutely true. I can't say that there's one specific trend. So just to talk about what we were saying before, we do work really closely with LPD when it comes to the high utilizers within our city. There are constant email chains where we're getting those names, we're getting those locations, and we're doing our best to reach out. I can't say that there's a specific trend of any one type of resource that is lacking more than the other, because we see the gamut, we really do. Now, that being said, I've lived in a lot of places in my life, and I feel like Lincoln does a really good job of connecting people to the resources that they could use to make their life a little bit better, their quality of life. So there is a lot of resources that are available to meet that hierarchy of needs. Part of my experience has been that a lot of people just don't know what resources are available, and being able to guide them to said resources really has been extremely beneficial, because we do a good job as a city. I feel like we really do. But there's no common trend that I can think of, really.
Yeah, we see such a variety of different things that affect the mental health, affect their daily living. One thing that has been really helpful that I'm sure everyone already knows about, but the My LNK app, it just has so much resources that we can give to people, and just letting them know that they can have this on their phone if they have a phone, and just making sure that they know that there are resources in Lincoln that can help them.
And let me add to that, because a lot of times people don't necessarily feel comfortable, or they're embarrassed, or whatever the case might be, to actually reach out to the resources, and being willing to sit there and do that with them could be potentially helpful. I saw somebody asking the question, how do you navigate handing your phone to a stranger experiencing a crisis if they don't have a phone, especially during COVID? And so in my office, we've moved to basically web-based phones where it's all through an app. And what I do a lot of times, and I'll just put it on speaker, and just put it on the phone, and just be like, hey, we're not allowed to give our phone over to somebody, but I would have it on speaker, and I would support them making that phone call. Sometimes people don't know what to say, or they don't feel like they have the words. They don't feel qualified to make that call, a whole bunch of different things. But just supporting them, contacting the said resource to be able to walk them through that process could make the night and day difference.
Awesome. Yeah, so you answered that question, so thank you. This is something I want to add to Sandra's question, which is great. What would be needed to staff a crisis line 24/7? And just to add to that, like, what can we, I love what you guys are doing, and I think your work is so vital and important. And so what are ways that we can support your organizations? And yeah, what is needed to staff a crisis line 24/7? Maybe it's just all of us donating a little bit of money, you know?
Money always helps. Absolutely. You know, that's a really broad programmatic question. And I don't have a great answer for it. I can just summarize with people. People are needed. Willing people to pick up the phone and actually support individuals. As far as for me personally, I think this kind of situation is extremely useful. You know, like-minded people coming together with the benefit of the community in mind, just having these conversations, creating a space where we can dialogue about what the real needs are, what our community members are seeing, and then coming together to try to equip our community to be able to handle the situations that arise. I strongly believe in collaborations. I'm a huge advocate for building bridges within the community. And I think that this kind of space, this platform is exactly what we need, because, you know, UCAT may know of resources that I don't know about. I may know of resources that you don't know about, and how we can collaborate to get that information out to be able to meet the need of our community members, I think is just instrumental for the growth of our community. So I really feel like this type of platform is extremely important.
Would it be okay? This is Sandra. Would it be okay if I asked a follow-up question?
Absolutely, go ahead.
All right. The reason I asked the question about what would it take is because I think we do need to collaborate to come to a solution. And I think what I've heard, you know, all summer has been a strong desire for mental health crisis to be dealt with by mental health professionals. And I am curious about some other communities have created crisis lines that are like a 911, but they don't ring up the police. And I wanted to know if there was really, I'm asking the question to find out if there's an interest to work that way, to collaborate across, so that it doesn't sit on one organization's responsibility to answer every crisis call, but to build something together that could respond to mental health crisis in a 911 kind of fashion.
Sandra, let me just give my personal opinion about that. I think that that would be amazing if we can handle that on a switchboard level so that the crisis calls get routed maybe to another resource that isn't 911 when said resource would be the most appropriate. So I think that that would be an amazing initiative if we could make that happen.
I think
Well, that's a goal.
I think that would be huge. I think some of the biggest barriers, just kind of looking at program development, is so much. It comes down to funding, and this isn't the most helpful and isn't talking about the community collaboration necessarily this platform is for, but it really comes down to funding sources. So even in building programs, oftentimes the grants or the funding sources are for a 2-year program, and so unless it is a centralized, government run or sponsored service, it's now putting it on the agencies to say, hey, you have 2 years of funding to hire people, to create a program and execute it, and then we'll decide if you get additional funding for it, has been at least my experience in it. And so some agencies step away from that, saying, we're not going to hire people where we can't guarantee them the longevity of it, and we don't have any ongoing funding sources to support it. And sometimes 2 years is even a short time frame to demonstrate effectiveness and productivity. And so really it comes down to the funding sources and making it sustainable. One of the biggest barriers, again, this is not probably the right platform for this. Some of the biggest barriers is the cost. You lose experience. You have a lot of new therapists coming in to fill some of those positions because they're available. But then as people advance in their career or choose to have families, having to step away from some of those 24/7 jobs just because they're not sustainable, or financially there's other opportunities even outside of the mental health world that people have to pursue. So making them financially something that is sustainable both for the organization and for the individuals doing it are some of the biggest barriers I've seen people run into.
Sandra, I'm really glad you asked that question. That's an excellent question. And I think it's something that people all over the city are thinking about. I know we have met with like Captain Morrow and Chief Blymeister, like even before this, at the height of some of this, just the social unrest around policing. And so just having open dialogues so that we all understand these issues better is really vital. So thanks for asking that question and for your interest and desire to be here and engage in this conversation. It's really important. So for Heather and Allison, Isabel asks, as a woman, as women, how do you navigate these conversations where you want to listen, but want to avoid sexual harassment? I've tried to engage with folks around the neighborhood, but especially with men, and they often make comments that make me uncomfortable. I also ditto that. That's something that I think a lot of women experience when they're trying to address like a potential crises, or they're concerned about someone, is like, you come up to that person, but you might, so, and yeah.
Amen. That's not a good answer. Oh gosh, Heather, do you have thoughts about this, your experience?
Yeah, I've had a number of experiences. I'm sure Chris has heard my experiences just in the office. So when I become uncomfortable with someone like making comments about my body or anything like that, I may pull Chris in with me, and just so it equals out to like, okay, like, and then if he's not available, I may find a supervisor or something like that. But if I think I can handle the situation, I might be like, okay, this is inappropriate that you are making these comments. Can we please stick to the topic of why you are here, why you decided to come see me? And if it doesn't get any better, I do terminate the walk-in or the call or whatever it may be. I may terminate it, and I will go to my supervisor and be like, okay, this is why I terminated it. And she's very good about validating my feelings of why I decided to terminate the walk-in, the call, because we as women, we don't want to be sexually harassed. We don't want to have comments made about us when we're trying to be professional. I don't know, Allison, I don't know about you.
Absolutely, yes. And there's probably some of it that I tolerate because I'm maybe it's a function of their environment. Maybe it's a way that they're trying to feel in control of the situation. I try really hard. It's really painful sometimes to try to approach it from a place of empathy of why are they doing this? What purpose does this serve for them? Again, this is much easier to talk about than actually do. I kind of have a script in my head of when you make a comment about my appearance, it puts me in a position where I can no longer help you. I'm going to ask you to stop or this conversation will be over. So it points out when you do this very objective experience, it makes me feel this is how I will respond, and then very, very directly follow that response. I can't help people that don't want to be helped, which sometimes is really frustrating because I so badly want to be a support, but you can't be, and sometimes it's not safe to be. So being really directive about, I won't tolerate this.
That's so useful.
Great. It's
so
hard.
I'm going super long and I just kept going because I didn't realize we were at time. So let's take a 5-minute break, go stretch your legs, go get more coffee, get a snack, and I'm not gonna leave because I have my coffee. So the break, come back 5 minutes from now would be 11:42. Heather, just kidding. I was gonna just small chat with you about your earlier response, but you go do what you do.
No, I'm here. I'm just working. I was just gonna. Everyone else's video is gone, so I was like, okay, I'll just shut mine off.
Yeah, no, I was gonna ask. We had a whole idea about doing a workshop on sexual harassment and like sex trafficking and stuff like that. Because like catcalling, all that stuff, and then when you're trying to like help someone and they start hitting on you, and you're like, that's not why I'm here though. So I feel like you kind of inadvertently addressed some of my questions around that in your last response. So that was great.
Yeah, perfect. I'm glad. Yeah, with the population we work with, I just never know who's gonna walk in and talk to me, and that's awesome. Like, that's why I love Centerpoint, is it's so different than what I'm used to working in, and I love that I don't know what my day is gonna be like. And so, but then there are some times where I do get those people who walk in, and I don't know how to deal with them, or that they make these comments and everything like that. And so, well, another good thing that we have at Centerpoint is called Vonage. And so if I don't feel comfortable, I will message my boss and be like, hey, can you come in just for like a couple minutes just so we can get back on track, because everything I'm doing is not working. Because they will try and just turn the conversation where I'm like, okay, we have to go back to this question I just asked you on like a safety plan. And they'll be like, they'll turn around to like, oh, how old are you? Are you seeing someone? Are you dating? Are you married? And you're just like, okay, we need to get back to this because you came in for this reason, not to hit on me. And so, yeah.
Yeah, I thought that was super helpful just because like, I know Allie and I, we've been canvassing and like, or we're just like walking to the place where we're going to go talk to people, and we see someone and we're like, you want to like help out. But yeah, there's been a lot of uncomfortable moments, but I really like that idea, Heather and Allison, of like, what are they trying to do in this situation to retain that control? Because I think that that's what it's about. We're like, and it really makes a lot of sense, especially when you think about like the way that men are socialized to retain control, where like accepting help might be really hard for them. And so like, that is one way that they can control the situation, is like commenting on a woman's body or something like that. So that was super helpful to like make that connection. I thought that was really interesting.
I also liked how just like I think sometimes there's a debate between like, oh, you should just ignore it, or you should get really mad and like flip them off, you know? So there's all this spectrum of response. And so I really like just like acknowledging it, being like, hey, that's inappropriate and that's not why I'm here. Like I really like it's not judgmental necessarily. It's just kind of pointing out, this doesn't make me feel comfortable, and that's not the space that I'm trying to create. So that's what I'm going to do. And I've been on the spectrum of ignoring it to flipping people off, and now I'm just gonna found a little place in the middle.
Yeah, that's so much easier said than done. That's a really great answer that I can give to you today because I'm not at work, but ask me next Tuesday and I'll tell you how it goes.
We'll wait.
This is Sandra. I'm
Oh,
sorry.
yeah.
This is Sandra, and I'm sorry. I was listening in, and I'm just gonna chime in and say, own it. There is something about assumptive power taking or assumptive power owning when you name it and you say, this is just the way it is. You will come off so much more powerful, and you will be amazed at what you can create.
That's really great. Sometimes, depending on the relationship, I don't do it in a crisis situation.
Well,
putting people in a place where they have to take accountability for what happened. Of saying, I'm really curious why you just thought it was okay to say that to me. I'm really curious what you meant when you said X, Y, and Z, and then putting people in the spot where they then have to actually give you an answer, and not letting them off the hook for that. No, that was a genuine question. I'm expecting a response from you.
Right.
Which is always interesting in certain dynamics.
Yeah. So I'm giving you guys some support. This is a good thing.
Thank you. I appreciate it.
So I'm going to hand it off to Nancy because I think we're finished with the portion where I was asking you guys questions. Thank you so much. That was really insightful.
That was incredible. And yes, I have learned so much in like the last hour and a half. So this has been really, really amazing. And we just kind of want to open up this last 20, 15-ish minutes so people can just kind of take some time to debrief everything that we've heard. If you have more questions for Allison, for Chris, for Heather, or Jacob, I think this gives us all the opportunity to kind of talk about some of the things that we've heard today, both from the LPD perspective and now from, some of these direct service providers. If you have specific questions about experiences that you've had, that you want to kind of think back to and figure out how to navigate. So we can just use this last portion of time to kind of debrief what we've heard so far, and also maybe help inform what we do next. This series of safety-focused workshops have been driven by what we've heard from the participants and, what we've heard from folks in the neighborhoods. So we can be better equipped to handle these kinds of situations or just educate ourselves and have the best resources possible. So I just want to open this up. Feel free to unmute, ask a question, share a story, whatever that looks like. And we'll do our best to kind of talk through some of those different things.
Chris, I wanted to ask a little bit more. You had said something about in response to something that Kat had posed about like what's helpful for getting both like kind of the word out and people feeling equipped and empowered to respond, as well as like supporting the mission and the services already provided by like places like Centerpoint. And you had mentioned this kind of space being really helpful and important. And I would love to hear more about like within that kind of space, what would you like to see? Like, and how many people in a kind of conversation would still be effective? Yeah, just tell me more like what could that look like to be most effective?
So that's an interesting question. I'm one of those weirdos that I really like trainings and I really like meetings and I really like those types of environments. And I don't have a great answer for you, Vic. But what I do feel is just being open and available to have dialogue, just being open and available to have conversations, and be able to just let the community know what it is that we're doing. I mean, this one's been extremely, extremely helpful, and just creating more spaces like this. Like, before COVID, I was all about these community type meetings and just being available in them, that interagency collaborations that we see here, and just continue to build up on these types of relationships. I mean, obviously now with COVID, things are a little bit different, but that in itself has given us the opportunity to expand our platform and expand our reach. You know, 10 months ago, I may not have been able to go in person to this meeting, but now I can do it from the luxury of my own home. So really just taking advantage of this type of media, of this type of platform, and really just getting the word out. You know, we're trying to do a big push towards like systematic change and all of that, and really being able to use the resources that we have to create the most impact that we can. And some of it just has to do with boots on the grounds conversations, you know, just conversations, people meeting up, having a nice cup of joe and just talking about what's going on in our community. And all of that being said, I just want to take the time to say one thing, and it's that we don't always need to have the answers, and that's okay. A lot of times when we're dealing with crisis, we feel like we need to know everything that we need to do. We have to have that checklist of 1, 2, 3 things that we need to do in the midst of a crisis. And that's not always going to be the case. There will be some instances in where we might not know what to do, and that's okay. And my experience has been being transparent about that. It's okay too. And just being clear. Look, this is a difficult situation. I'm not really sure what to do. Let's troubleshoot this together. I think that's a very okay response to crisis. Because sometimes I feel like we have this expectation in our mind that we always need to have the answer, and that's just not realistic, and it's probably not going to be the case. So I went off on a rabbit trail, but I really wanted to say that.
That's a very helpful answer. And in fact, Heather and Allison or other people too, about like what they would like to see in kind of a continued thing, please do feel free to offer.
Vic, I think one of the most helpful things that I would show up to in a heartbeat is just knowing what resources are out there. So much of my job is in crisis Googling things, probably more than my clients would like to know my job is Googling things. But just knowing the resources out there, just having a round robin, I just think would be one of the most helpful things to know what the resources are. Because once you hear it, you're like, oh, there was that one place that we saw that I know they work with this, you know, people with this issue, or they have these resources or funds available would be huge. And I think one of the biggest barriers is not knowing, and it's hard to keep up because they change fairly often. So that would be huge.
Yeah, and there are currently a couple avenues that's being done in. You know, like Chris has identified, things have gotten weird, and I think we've all kind of lost a lot of those connections that. Well, I know like Chris and I are real people-y, but so you know, there's a provider level meeting. It's you know, it's very professional. It's a lot of agencies get together. Tim from LPD's there. Captain Morrow's there often too. You know, the agencies. It's called Level of Care meeting. Also Homeless Coalition. I know there's some familiar faces here, but it's been pretty much revolving around COVID and prevention and CARES Act and a lot of that stuff. But that is a really good platform too for resource sharing and such. So yeah.
And to add to that, there's a lot of spaces like that are available. I mean, my opinion is we don't necessarily need to reinvent the wheel. You know, like I'm part of this thing called the Nebraska Peer Advisory Board, where it's peers all along across the state of Nebraska that are creating a network to be able to stay in touch and share resources. You know, there's so many different coalitions and things that you can be a part of, and that for me has been instrumental in knowing what resources are available. So a lot of it does have to do with, you know, what's your level of involvement. The more you get involved, the more you learn. The more you learn, the more I feel like of an impact you can have. So for me, that's been great. Not to say that this is redundant, because it's not. And I think this is a great space. I just think we need more of it.
That this is the last thing I'm gonna say, and I'm gonna stop taking space for myself. But I think that I see like, and with what Sandra was talking about in like the partnership to make this sustainable, and Allison, you pointed out the issues with funding. So seeing in addition to something that is structured, that is sustainable in that kind of part of response, but then also thinking about like, how do we create more mutual networks of like, because there's the resources of funds available and services, but then there's just the resources of people who are in the lives of the people who are going through crises. And for myself, when navigating my own crises, like, yes, those other sources have been important, but it's been just as important to know who's in my personal network. And bridging network to networks, especially if we're looking at very like localized neighborhood levels of like, yep, it's Tony who like sits on that bench over there and has really rough days sometimes. Like being able to know then the interpersonal parts of the networks, I think, is something I want to know more about how to do and how to build those, yeah, so thank you for that insight, all of you.
Yeah, I think this conversation has been super helpful. Just because, like, I know that some folks had expressed this discomfort in like hearing time and time again that we should be calling LPD because they can de-escalate the situation. But hearing from you all that like that I mean, people would end up in your services anyway. I think that that gives me a little bit more confidence to be able to think about alternative ways that maybe aren't as re-traumatizing for folks to get the help that they need. And I hope that like in the future we can have this conversation of like this not re-education, but just like rewiring in our minds of like crisis, call 911, you know, like what are the other options, what else is available. I think that a lot of folks are really excited about this, kind of like Councilperson Washington was saying, is that like what are the alternatives and like how can we fund those and how can we make it that public-private partnership, and then how can we get out that that message to the broader community and our communities and our neighborhoods to make them stronger that way.
I just want everyone, if you haven't already, this is a challenge. I'm challenging you. Pull out your phone, go to the add contacts, and enter the Centerpoint crisis line into your contacts. I'm going to do it right now. So the next time you see somebody that's going through a mental health crisis or a substance abuse situation, and maybe you do or do not feel comfortable, you know, just think of that as something that you could have as a resource. Amazing. Yeah.
Absolutely. And to take it one step further, I mean, I would definitely put myself at the disposition of y'all if you guys need additional support. Like, I know I'm more than willing and able to support you guys if you do come across a crisis. I know our outreach team would be more than willing and able to do it as well. So it's not only a number, you got a name and a face behind the number as well.
I have a question about aftercare, and so let's say my neighbor is having a crisis and the situation was thankfully able to be resolved in that day and in that setting, but then the next day I want to follow up with them. How can I do that without, you know, adding to what might have been the trauma of that situation?
So my experience has been that having follow-up conversations does not re-traumatize, but quite the opposite. It gives somebody an opportunity to open up and to share. There's a common stigma that like talking about suicide gets people suicidal. That's research would show that's not the case. It really just creates a space where individuals can speak about what's going on. And that's been my experience as well. A lot of what we do is follow-up calls. If individuals were really having a rough time, whether it be on the crisis line or on a walk-in, we follow up with them a day or so later and be like, hey, just following up. How are things going for you? And that really opens up the door to a lot of conversations. And quite frankly, a lot of the times conversations will go, well, oh, doing okay now. Thank you so much. I really appreciate you following up. Cool. All right, we're here if you need anything else. Just so that they know that there's still somebody who cares and that they can reach out and that that's okay if they need to. Sometimes the conversation go other ways and we have more conversations, but yeah.
I have a question for the group if we want to do this, and if you want to type it in the chat or say it out loud. I'm really interested for everyone here. Is there something that you like learned today? Maybe in brief, since there's a lot of us, but is there something that maybe you came in thinking and then your assumption about that thing changed? Or yeah, what did you guys get out of this?
One thing that I really appreciated was learning how to set boundaries when reaching out to folks, especially if you're experiencing sexual harassment. Allison, when you said that if somebody makes a comment about your body, that puts you in the position to not be able to help them, that was great advice. That was a wonderful tip, and I will definitely be using that if it comes up.
I think that Chris was able to emphasize something that and I think he said like that we often complicate this, but getting a demystified look. I've done some direct care, not in this field specifically at all, but like knowing that like the person who's responding, yes, like you have other trainings and that you're a professional and you're doing this and you have other like, you know, networks around you, but really the mechanism that you're doing when you first arrive or engage is talking to someone and just having a conversation and trusting like your intuition and instinct in addition to the training and like professional knowledge that you have, but like knowing that that is kind of the tool that you're initially just using. And then Allison, what you said about like someone has to know that someone knowing that you care is far more powerful than really high tech like treatment tools. And yeah, and so how do we sustain just people being able to care? Because also saying out loud, it is expensive to care in terms of like energy, time, and capacity, even though it's not actually costing anything to care. As a sustainable thing, like responding to our community's needs, it is, it takes a lot of resource.
And to add to that, Vic, if there is anybody that would like additional training, I mean, Region 5 Systems continually offers free trainings that are open to the community. You have like things like QPR, question, persist, respond, refer, which is a suicide gatekeeper type training. They have mental health first aid, which anybody can go to. They even go to schools for some of that stuff. So they have a slew of different things that you can do, and most of them are free trainings. So Region 5 Systems, right on their website, you can find all that stuff.
That's really good, because I think one of the things that I feel like I'm very naive a lot of times. Like I really struggle in picking out when a person is like using or on any sort of substance. And so like I'll be walking down the street and be like, that's weird that they're walking down the middle of the street and kind of like sleepy. And then my partner's next to me and she's like, he's like on something right now. And I was like, I had no idea. So yeah, I'll definitely look into that. And I would love to like learn more about identifying those things that give a little bit more context to someone's situation. So like maybe guiding him towards the sidewalk would have been a good thing to do if that felt safe.
I also want to add that I really appreciated hearing Michonne and Tim, was it? Tim? Yeah, their perspective, and especially when it comes to protocols for EPC. And I had heard that the EPC rate was low, but I didn't know it was 10%. That's really encouraging for me to hear. So I really liked their take on things.
Yeah, I think for me, just having all these different perspectives, and I know you all agreed on a lot of different things, but I think hearing from all your viewpoints of, you know, being at Centerpoint or your respective agencies and providing that context. So we as individuals in our neighborhood are just better equipped to handle some of these situations if we feel comfortable. And, you know, Allison, something you said early on, and I keep going back to it, is just like, having a conversation with someone really goes a long way. Just asking that question of, hey, what's going on today? Like, is there something I can help you with? And that's kind of what our work is all rooted in within Collective Impact Lincoln already, and what we do in the neighborhoods. So it's not that far off from what we already do as neighbors and as colleagues and as friends and, you know, all of these things in our respective circles and communities. So I think just kind of keeping that in our mind and going back to it, if we are in a situation where we feel uncomfortable or unsafe, or like something is transpiring here and we don't know exactly what to do, is just going back to that place so we can try to help the best way that we know how, or the best way that we might be able to. So, well, it's noon. I don't want to cut anybody off. Kat, did you want to add something before we wrap up?
I just wanted to thank everyone for being here. And I also wanted to give a little shout out to Mika and Allie, who made a takeaway doc that will go out to all the folks that registered for this. So you can just put that up on your fridge, and then when you have questions about how to handle something, you can go to that or go to your phone where you added the Centerpoint Crisis Hotline.
Can I add some shameless plug real quick? I guess it's not really shameless.
Yes.
So I saw some things just, about some folks like kind of realizing what Centerpoint does. Like, it's a place on 13th and East Street or whatnot. But I'll be quick. We offer a lot of services too. So we do have, like, I work in the housing world, which we offer quite a bit of housing for individuals, taking folks off the streets and such. But wanted to really kind of push our, we have a physical health clinic now. So I'm trying to just show we're really trying to wrap around the whole the whole individuals with, mental health, substance use, physical health. Like we're becoming super rad in this century. So
one more thing that you forgot to mention is we just added children and families as well. So we're able to do children and family, not just therapy, but peer support and case management also. So
we have a website.
It won't be able to be called Center Point anymore. It'll be Center Points. It's just going to be so encompassing. That's exciting. That's cool to hear. Thanks for the update.
I just want to thank you guys for letting me be a part of this. And I put my email in the chat box. I'm not great. I'm not a 24/7 on call, so don't use it in the middle of a crisis. Please reach out to Centerpoint. But if this has been interesting, or if you have other follow-up questions, I would love to be a resource. Please don't hesitate to reach out anytime.
Thank you so much. Thanks to our panelists. Thanks to all of our participants today. I will send a follow-up email to everyone with our evaluation so you can give us some feedback. So we as Collective Impact Lincoln know what we want our next workshop to be focused on, or what part of this conversation we can continue, and who should be involved in that conversation and what that might look like. So I will send a follow-up email, and I just want to thank everyone so much today for joining in this conversation. We know it's not easy, and it's a tough one to talk about. So we really appreciate everyone's perspectives and just being a part of the conversation. So I think we have one more nice day of fall weather today. Sorry if anyone hasn't looked at the weather forecast. I apologize, but please go enjoy the rest of your Saturday and your weekend. And thank you again for joining us.